So this is video 1 for chapter 12, anal fissure. A 36-year-old woman has been referred to your clinic with severe anal pain after defecation. How will you assess her? So a targeted history, that how long does the pain feel? Is there any rectal bleeding? Has there been any change in the bowel habit or any other drug-related symptoms? Then we'll go toward the examination. On examination, I will do inspection and palpation, and in my head will be to see any physical sign of anal fissure, sentinel skin tag, malignancy, hemorrhoids, any previous surgery. And digital rectal examination may not be tolerated, but if patient tolerate, I might examine. Next question is, the patient has a sentinel tag, but it's too painful for her to tolerate a DRE. You suspect anal fissure. What you do now? I will give her a dietary lifestyle modification. I will give her some stool softener. I will give her some Instilla gel, some analgesia, and specifically I will give her some topical diltiazem 2% cream or GTN 0.2% cream for 8 weeks to apply BD perfectly, and that will, the results of this topical cream is 60 to 70% in literature. So third question, she comes to see you 8 weeks later. The topical cream has not worked and she is still experiencing severe pain and bleeding. So what will you do now? So now I will get a bit more concerned that her symptoms are not settling. So this time I would list her for an EUA, urgent EUA of the anorectum, and then we will rule out any anal squamous carcinoma, and I would do a biopsy of any induration or suspicion area, and if I will do a rigid CT or just Eisenhammer, and if EUA was normal, I would inject Botox into the internal sphincter on either side of the fissure, total dose of 50 units, 25-25, which heals 70% of the fissures. So the complications of Botox are transient incontinence and hematoma, pain, and sepsis. Okay, so this will be your first. If this doesn't work, I will perform the patient's anal manometry and endometrial ultrasound, looking for resting and squeeze pressure in the sphincter and to assess the anatomy of the sphincter. And if this lady is planning to have future pregnancies, then I would not offer her a lateral sphincterotomy, because obstetric injury following the delivery can give catastrophic implications. In a male patient of same age, I would discuss the procedure, including the risk of permanent incontinence to flatus, that's 30%, and fecal soiling of 10%, and fissurectomy with anal advancement flap is a further surgical option in a non-healing fissure, but success rates are variable even in a very experienced hands. Thank you.